C4 and Brian Neiman. Heard weekdays from 5:30 to 10 a.m. on WBAL News Radio 1090 and FM 101.5. Now, the C4 and Brian Neiman podcast on WBAL.com and the WBAL app.
We are pleased to bring you the fourth Townhall special in a series, Brian Neiman, of Townhall specials with our partner, Greater Baltimore Medical Center Healthcare, GBMC Healthcare, in an attempt since March when Maryland and our local jurisdictions, really the middle of March, put in place many of the restrictive procedures related to COVID-19 that have altered and changed our lives. And we tried to educate you through medical professionals that GBMC Healthcare has provided to us, Brian. And it's just been an amazing partnership we've had.
It has been great, and we've learned a lot, and we're going to hopefully learn a lot more today.
Let's bring on board the first of our guests, Dr. Theodore Bailey, Chief of the Division of Infectious Diseases at GBMC Healthcare, who's been on board with many of these with us. Good morning, Dr. Bailey.
Morning, Dr. Bailey.
Good morning, gentlemen.
Let's first get started with something that just recently has been in the news, Dr. Bailey, in the last couple of days. The FDA has said even when we first get our first couple of vaccines that might be available to the public, they want to have a 2-month process to review the impact of those vaccines. What are your thoughts on that as a policy?
I think that's an excellent policy. That's the kind of attention to detail and scientific data that I would want in anything that's going to be rolled out in as large a quantity as such a vaccine would be. The whole point of doing a clinical trial in the first place is so that if there are defects in it, where it's either not helpful or even potentially harmful, that we catch that at an early stage where a limited number of people have been exposed to it and are affected by it, rather than rolling it out to millions of people and then finding out that there is some danger to it, because that just magnifies the impact that has.
Do you have an idea of how it's going to work? Obviously, there are different pharmaceutical companies that are going to have different vaccines. Are they going to be specific to one age group or one type of person? Or how is it going to be rolled out? And do you think that maybe one will work better than the other?
Well, what we would want is a rollout that's driven by the data, which is to say that taking a look at the different demographics and the different characteristics of the people who went through the trials and seeing who benefited from it, who might have been harmed from it, will help guide who should or should not get it. So it shouldn't be something that's declared in advance. That's actually the kind of guideline that's driven by the results of the clinical studies.
You're listening to The Coronavirus, our fourth Town Hall special in partnership with Greater Baltimore Medical Center, GBMC Healthcare. Dr. Theodore Bailey on board. And Dr. Bailey, many of us have become aware of the rapid COVID-19 test because of President Trump testing positive recently. But what is the antibody test?
Well, the antibody test tests for whether you have been infected with it at some point in the past. It doesn't necessarily mean that it's presently in your body. But what we're testing for is the body's own response to the infection. And the body, in response to infections, makes a special kind of molecule called an antibody that helps fight and remove an infection. But the whole point of the immune system is to not just make it at that moment, but to continue to make it for some time to provide lasting protection in case one were to be exposed to the thing later on. And that's the basis for vaccines also, because we can get the body to continue to make antibody after a vaccination. So when we test for somebody with the antibody, we can tell them that they've likely been infected from some point, maybe a week or more in the past. And we're seeing some information that the duration of the antibodies may not be lifelong. We see that they may taper off after several months. But if we see them, then we can probably say within the last 3 months, maybe further back, that there has been an infection. We like to hope that we can also tell them that they're immune to it, but we have not been able to sort of make that link yet in a conclusive or convincing way, because antibodies are one of the things that's hoped for to confer immunity. So we would hope at some point to be able to prove that, and then we could test people, not just have they had an infection, but are they immune? Are they somebody who should not have a severe case of the infection if they go forward?
Well, what about all of the molecular tests that we have right now, the diagnostic tests? And obviously this is a big deal with the White House right now. It's a big deal with the NFL. How accurate are they? And I mean that in two ways, because there are a lot of people who get tested and they wind up negative and think, now I'm pretty sure I had it. And the other way, too, especially the PCR test, there have been reports that it's too sensitive and that there are a lot of false positives out there. What do you think about, how reliable these tests are?
They have limitations. The reliability falls into two kinds of categories. If you get a positive result, does that really mean that you have the virus? And I will say, you mentioned molecular tests. Let's distinguish that from the antibody. Now we're testing directly for the presence of the virus or some part of the virus. And that last little bit that I said is really the rub, because we're detecting possibly just a part of the virus. So it's possible that when we get a positive result, we may be seeing debris left over from an infection that's no longer transmissible. The test really can't answer that. There is a more academic or research-based test called viral culture, where we can attempt to take somebody who's test positive on the molecular test and then see if we can recover a virus that is actually replicating itself. We believe that several weeks after, and I would say approximately 2 to 3 weeks after infection, that even if we detect positive results on a molecular test, those may just indicate debris left over from the virus. It's not a replicating virus, not a transmissible virus. But this is still not perfectly well defined. And
Chief,
I'm sorry. Go ahead, C4.
Chief of the Division of Infectious Diseases at GBMC Healthcare, Dr. Theodore Bailey, is on board. And Dr. Bailey, with the big debate we have going on right now about potentially high school sports and what might happen with close contact, we also see at the professional level. In today's news, we have the Tennessee Titans having 2 more players test positive, and New England Patriot has just tested positive today. What do you think should happen at the professional level, really just in terms of close contact types of situations?
You know, when you have somebody like that, you really want that individual to be quarantined, and which is, or I should say, isolated. We want to make a distinction between those two. Somebody who is known to have the virus is somebody who we would call isolation. They would be set aside, not having direct contact with individuals for a 2-week period of time, typically. But then quarantine is something that we recommend for folks who've come into very close contact with someone who has recently been found to be positive. Because there's a good chance that they would have acquired the virus too. They may not have symptoms, but they might have it, and they might be able to transmit it. So general recommendations are to quarantine individuals who are in contact with someone who's a case, who's had the infection recently. So in the sports context, that sometimes means shutting down a team, essentially taking the individuals who've been in close contact with each other and having them step away from the other individuals who may not have been. Maybe they were on other teams, special teams, defense. They weren't in, say, the same kind of close proximity. Basketball teams, obviously, everybody's in close proximity. They all work together. But it's certainly something that would be destabilizing to the normal conduct of sports practice and sports competition.
There's so many different questions I want to ask you, but I'll have to ask you about the children, because obviously school is a big issue, and elementary school kids are going to be different than high school kids. What do we know today now on October 7th when it comes to kids, the role of children, especially younger children, and the transmission of COVID-19? Because I know this is a big deal, especially with teachers.
Well, we know it seems that if you take one child and one adult and we're to compare them, one child with COVID and one adult with the COVID, the child with COVID may shed less, 1-for-1 with an adult, but that doesn't mean that they don't shed enough to transmit the virus. And so children can be a vector, a point of transmission for the virus, and that does make schoolrooms and school settings concerning, because you're talking about a large number of individuals around each other, and then those individuals also don't only link to each other, but they go back to their houses, and so it's a way of linking houses to houses through the intermediary of a school. So it's a concerning type of social contact that certainly has the potential to transmit it, and we have seen acquisition of the virus in some severe cases and even fatality, on the part of teachers. So it is a risky environment. It speaks to the need for certainly masks, disinfectants, mechanisms of distancing in the school setting. Can you stagger classes? It also speaks to serious consideration to maintaining or enabling virtual education, where families are able to get high-quality education, but do it without accessing a schoolroom.
But we haven't seen a whole lot of transmission, right, from kids to kids in schools? I mean, that has been what we have heard all across when it comes to the health administrators in counties all across the country.
Well, and that speaks to the fact that, what happened in the spring was fairly widespread shutdowns, and then summer where people were going to be naturally socially distanced anyway. So, we're really about a month in to an infection that has an incubation, a month into school season, where the incubation time of this virus is approximately 2 weeks, can be. And so we really would be looking at it maybe in the October or November. This is something that based on what we know about the ability of children to shed and the ability of children to acquire the virus, there's no reason to believe that they would be exempted from it.
Dr. Theodore Bailey, Chief of the Division of Infectious Disease at GBMC Healthcare, thank you so much for being a part of our Coronavirus Town Hall Special number 4. Thank you, Dr. Bailey.
Thank you, Dr. Bailey.